Welcome to this Wednesday afternoon GECCO meeting. The focus today is going to be on hepatocellular carcinoma. I'd just like to thank a few people, the Gastro Foundation in association with Project ECHO and the University of New Mexico. As you may know, the GECCO meetings are held weekly on a Wednesday. There've been 94 registrations for this meeting from 14 countries, predominantly in Africa, but as far away as Peru and Portugal. We're going to start off with Professor Jonas giving a talk on local ablation of HCC in the sub-Saharan African context. And then we're going to have two MDT type case presentations by Rashid Mashdingo, who's an HPB surgeon in Windhoek, and Yildiz Ziai, who's a HPB fellow at Groote Hospital in Cape Town. If anyone has any questions, please feel free to post them on the chat, and we will get to them. Alternatively, we'll have time for comments after each presentation or talk. All right, over to you, Ed.
Thanks, Mark. I'm just going to share my screen. Is that the presentation view?
Yes, that looks good.
Okay. So welcome, everybody. So as we've mentioned in the first meeting that we had about 5 weeks ago, that we will start these sessions with a topical talk on HCC, followed by the MDT component. So this week we thought we would just share some thoughts with you on local ablation of HCC, that for a number of reasons are really important in Africa. We'll come to that. So where it fits into our treatment algorithm. So here back to the Barcelona criteria, and you can see here at the bottom that in a best case scenario, about 30 to 40% of patients should be treated with curative intended interventions, and that would include resection, liver transplantation, and then local ablation. So for some reason, they still specify radiofrequency and percutaneous ethanol injection, but that would also include some other methods, as I will show you. And then with a target, as I said, of 40% of patients, and we aim to get a median overall survival of 60 months and a 5-year survival somewhere between 40 and 70%. So just in summary, these are the patients that, according to the Barcelona criteria, would be eligible for a local ablative treatment. Again, quite strict. So we divide it into 3 components: the tumor component, the function surrogates that we use here, the Child-Pugh score, and then as general condition. So for a patient to be eligible, 1 to 3 lesions, none of them bigger than 3 centimeters, and the Child-Pugh score A or B, and a performance status of 0. And I think one can certainly challenge some of these very conservative guidelines, especially the performance status. So if you look at the whole menu of what can be regarded as local ablation, certainly the oldest one and the one that has been most used, ethanol ablation. Then we get, and these are the needle-borne ones, as I wrote there, radiofrequency ablation of the heat-producing or heat-using modalities. That's the one that's been most commonly used, but microwave ablation, I think, has in many centers replaced radiofrequency ablation. Then laser ablation, very experimental and limitations in terms of size. Cryoablation, for various reasons, we have certainly never used. And then IRE, or irreversible electroporation, a newer method with certain strengths that can solve some of the problems that we run into with radiofrequency and microwave. And then, just for completeness' sake, external local ablation methods like high intensity focused ultrasound and also stereotactic body radiation therapy, mostly used in lungs, but can also be used in the liver. So I'm just going to quickly run through the ones that I think are mostly used these days. So ethanol injection, the oldest of the whole lot. You calculate the volume of the ethanol that goes into the lesion with that formula that I show you there, and you add a 0.5 centimeter margin to try to get some of the volume of the ethanol into the surrounding liver tissue. It can be quite challenging if you've got a cirrhotic liver, because it works very well on the tumor that is usually soft compared to the rest of the liver, but has got a problem to sort of penetrate the surrounding tissue. And the mechanism of, you can see there, you get a coagulation necrosis, dehydration, and protein denaturation. So radiofrequency is really just a current. So you need a ground plate for this, current running through the patients. You get oscillations in the radiofrequency range of water, and that would create the heat effect. The disadvantage of that is you do get carbonization, and after a while, there's a sort of a reduction in the way that the heat is transmitted, and there is a limitation in terms of the size. Microwave ablation, a little bit quicker. It's pretty much the same as a microwave oven, with the difference that the generator is a needle. And then IRE, a newer method, very cumbersome because you work not with a single needle in the lesion, but with a lattice of needles around the lesion. And I will show you just some images of that. The big advantage there is that you actually preserve scaffolding. So where we've got issues with burning close to the major bile ducts and some of the vessels in the liver that we need to preserve, that you can actually go around them with IRE. Because the scaffolding is preserved, you actually maintain the integrity of the bile ducts. So what it's really all about is what access you are going to use, and the navigation. And that is universal for all the needle-borne technologies. And just to summarize what we want to achieve, the position of the ablation device, we want to position the ablation device in the most accurate and less invasive and safe way to enable complete ablation of the target lesion or lesions if there are more than one. So we can do it percutaneously, we can do it laparoscopy assisted, and we can do it laparotomy assisted. So that would be your access. And then in terms of the navigation, ultrasound guided, CT guided, MRI guided, or computer assisted. And I'll just quickly run you through those. So I think still that although it is a bit more invasive, that laparotomy assisted ablation is probably the access method that has been associated with the best results. You can see here, liver, this is not a HCC, it was a patient with multiple colorectal mets, and you can see the ablation holes there. And there are a couple of advantages with that laparotomy assisted. So in terms of detection, we use ultrasound on the liver with quite a, and you can vary the frequency to quite a high frequency that makes your detection better. You've got visual inspection of the liver and the advantage of bimanual palpation. You can do additional staging. You can exclude peritoneal metastases, for instance. And then the needle placement is really, you can basically come in from every angle. You don't even need to go through the incision. As long as you can visualize the tumor with ultrasound, you can actually go through the abdominal wall away from the incision if that would be an easier angle. You can also mobilize the liver to facilitate access to the lesions that may not be accessible, for instance, with percutaneous, and also do some distancing, taking away some of the organs that could be damaged by the heat, the stomach, and so forth. And then the heat sink effect that is a problem in all the heat based methods is that if you've got big vessels running past the tumor, that it works like the sort of the coolant in a motor car, in a car engine, that you get a heat sink effect and that you don't actually get up to the desired heat to kill off the tumor. And if you're going to do concomitant resection, that is possible. So laparoscopy assisted, that is clearly less invasive, gives you all those advantages. You lose your your sort of tactile feeling, obviously. And then when you want to, if you would like to exclude the liver to minimize the heat sink effect, you would not be able to do a total vascular exclusion, but you can certainly do a Pringle maneuver quite effectively that would at least slow down the flow in the liver. When it comes to percutaneous ablation, we really use many of these sort of fringe benefits of the other two access methods, but certainly the least invasive and quite frequently used. When it comes to the guidance, ultrasound guided, I think by far the most commonly used method, widely available, quite cheap, the precision is good, and there's also contrast agents available, unfortunately not in South Africa, and I think many of the other countries in Africa have got problems with that as well. And I'm going to tell you soon why that is important. The problem is that the ablation area is difficult to assess, and obviously it is very operator dependent as well. So if you look at the contrast agents that are available for ultrasound, the one that is most commonly used is SonoView, basically micro bubbles that circulate through the body, and it gives you very much the same contrast enhancing patterns that you would get with any sort of intravenous contrast, regardless of imaging modality. So it would be more or less the same as for CT with contrast and even MRI with contrast. I'm just going to show you here. There you see quite a big sort of low echogenic tumor there. The contrast is being injected, and you will see how it lights up in a while in comparison to the surrounding parenchyma there. And then a little bit later, you will see the washout. So this would sort of confirm the typical brightening up in the arterial phase and the washout in the venous phase that you see with the other contrast methods as well. And it's particularly useful in a liver full of macro nodules, where somewhere there is an HCC hiding, and that's the way to detect them. As I said, unfortunately, we don't have that. So CT guided has got advantages, but logistically it's much more difficult. We have access to that, but it's a bit of a mission. MRI guided, even more complicated because you need special equipment, obviously, that would tolerate the magnetic field. And then I think still something that we dream about here in Cape Town is the computer assisted, where you, with navigation, can actually find these different lesions in the liver, and with reconstructions actually can predict your ablation zones and so forth as well, but certainly not something that we've got access to. So local ablation with radiofrequency and microwaves, they're all needle-borne. At the top there you can see microwave ablation needles. Here you can see one of the examples of a radiofrequency needle, and this umbrella type where the needles sort of go out into the periphery. They try to improve the size of the ablations that you can achieve. But in general, you do not come up in the ablation size that you can achieve with microwave ablation. So IRE, just to show you what it's about, so you can see that lattice of needles that you have there, placed around the tumor. This is placed with computer-assisted navigation. That's the only way that you can get these things in percutaneously. Otherwise, you have to open the patients. Very cumbersome and still very expensive. So I think in the region of about 8,000 euros it would be per patient. So if we come to the sub-Saharan African context, and this is a slide that I showed at the first meeting as well, compared to the stage at which tumors are diagnosed compared to Europe, and I guess most first world countries, that we have a problem in sub-Saharan Africa, that only 5% of patients will be diagnosed at a stage where we can offer them curative intended treatment. And this we also showed, the article by Lewis Roberts group, of how few patients in Africa actually are treated with curative intent. And you can see here that in this series that no patients actually had local ablation. we must realize that the reality in Africa is that most patients will present outside of the Barcelona criteria, where there is a size limit. So there is a lot of treatment going on outside of the Barcelona criteria for basically all modalities, one can say. But you can see here just one article where they looked at ablation outside the Barcelona criteria, that the survival was actually, sorry, the first one there must be less than 3 centimeters. Sorry, if you do it more than 3 centimeters, there's two consequences. The one is that you get an increase in the local recurrence rates because you obviously may not cover the tumors completely. And also that you're dealing with an oncologically more advanced patient. If you do patients with more than 3 lesions, that would be the equivalent of having more liberal criteria for liver transplant, and that is equates with worse outcomes in these patients. So what about if a patient would qualify for all 3 of these treatment modalities within the Barcelona criteria, and you can pick and choose? The reality is that if you stay within the criteria, that the outcomes in terms of 5-year survival between the 3 methods are not all that different. There's certainly a bit of a variation between centers, and centers centers of excellence in local ablation will probably have better results. But just quickly, if we look at resection versus transplantation, which this is just one meta-analysis published about 5 years ago, where they looked at unfortunately no randomized trials, but the conclusion there was that the outcome between patients resected and patients transplanted within the Barcelona criteria were not all that different. If you look at this recent meta-analysis published just a couple of months ago between the resection and local ablation, you can see here that resection altogether did better than local ablation, and that was also their conclusion, that the liver resection is probably still better than ablation. So what about microwave ablation versus radiofrequency ablation? In reality, you get a larger ablation diameter, and the longer you're going to ablate, the bigger that is going to get. There is a limit, but you can certainly, if the tumors are well placed, ablate areas up to 5-6 centimeters. You get a more uniform ablation with consistently higher temperatures. You don't have the sort of carbonization effect that makes it less effective, and it's much quicker. So you get a lot more ablation for the time that you ablate, and it seems to be less prone to the heat sink effect as well. The fact that it's a sort of a single electrode, there's no risk for patch burns. But I think we have to look at ethanol in sub-Saharan Africa, because whereas all these heat-borne methods are certainly more effective than ethanol, there are enough studies to suggest that ethanol, especially in small lesions, still is really not a bad option, very cheap. And just interestingly, the needle placement, if you're going to do an ethanol ablation, is not that important because the ethanol will diffusely sort of spread through the tumor bed, almost regardless of where the lesion is. As I said, the problem is to get the ethanol out into the periphery. Okay, I think that's all I had on that. I don't know if there are any questions or comments so far.
Thanks, Ed. I see there's a question from Onasai. Is there a difference in the allowable ablation margin versus surgical margins?
When it comes to HCC, they say one of the reasons why ethanol is not working very well is that with these sort of micrometastases that you get adjacent to the tumors, that you do not address that. And I think one of the reasons why the heat-based methods are better is that we add, you can effectively add a rim of ablation around the tumor by increasing the size. So the efficacy of the heating up does not depend on the texture of the liver. Whereas with ethanol, it just doesn't go into the ethanol doesn't go into a cirrhotic liver. And I think one should consider a centimeter margin, should aim at least for that, if possible, if you do a heat-based ablation. The reason is that it's very seldom that you get sort of a bull's eye here, placing especially in the bigger lesions, the needle optimal, so that you really get a uniform ablation of the tumor. So I think that probably have to aim for a bigger margin when you ablate than when you do a resection.
Thanks, Ed. Does anyone else have any questions or comments?
Hi, Mark. Hi, Prof. It's Karan here. I was just reading some articles about some, I think in Japanese studies where they're trying to ablate bigger lesions, and they basically don't focus the ablation center on the center of the tumor, but they go like almost around the tumor, and they try and have an overlap that would cover a larger ablation zone. How do you have any thoughts about that? And should we be trying that in cases where we don't think resection is a possibility? Or I don't know.
Yeah, so I mean, if you go again, if you stay within the criteria, and especially with microwave ablation, a well-placed needle there will probably sort it out. But there are groups. There was a nice lecture on the EHPBA teaching platform about a month ago from Innsbruck, where they do sort of a grid ablation of much larger tumors, where they plan beforehand how the needles go in, and they even do a radiologically sort of a hemiapatectomy on some of these patients. But certainly, if you've got a larger tumor, one of the ways that you may sort of get around or get to ablate the whole thing is to, in a very planned fashion, to do multiple ablations in different areas of the tumor.
Ed, you mentioned that alcohol ablation works better for smaller lesions, and that 3 centimeters is sort of the size, the most effective size for that we'd like to go up to for microwave ablation. What size lesion do you think is reasonable to ablate with alcohol? Because alcohol is something that's going to be widely available, but what do you think is a reasonable size cutoff?
Difficult to say, Mark. I think the bigger they are, the less likely you are to get the whole thing. So what I wanted to come back and why I mentioned ethanol is in areas where we haven't got any possibilities, even not resection, and where patients can't be referred. That there may be a subset of patients where ethanol ablation for smaller tumors may do the job. But I think if you get above 5 centimeters with ethanol,
right? I think if there's no other comments, I think we'll move on to the first case, which Rashid Nasradengo is going to present. As I mentioned, Rashid is a HPB surgeon in Namibia. While Ed gets the case up, we were actually going to present this case 5 weeks ago at the first meeting, and we didn't really get to it. So we discussed the case after the meeting, and this patient has actually been treated, but I'm not going to say what happened. So over to you, Rashid.
Good afternoon, everybody. Thank you so much for the opportunity. So the case that we are presenting is that of a 56-year-old male who was referred to me by a surgeon. He's a Navy officer at the coast. He's sober habits and he's married with children. No history of smoking or ethanol abuse, and there's no malignancy of note from his family. Of note, medical history, he has been for hepatitis B for over 15 years, according to him. He's been getting Abicavir 0.5 milligrams all this time, and he's also HIV negative. Of note, his hepatitis B has been virally suppressed with his treatment. So he presented to the referring surgeon with persistent right upper quadrant pain or discomfort. He didn't have any other symptoms of obstructive jaundice or weight loss per se. And on general examination, that's nothing really of note. Other than just the discomfort or the slight tenderness in the right upper quadrant, he didn't really have any features of chronic liver disease per se, and he looked relatively healthy. From his blood workup, his HP was essentially normal. His urine is also normal, and his synthetic liver function, the iron was also not elevated. His bilirubin was also normal. Of note, during that time, his ALP and GGT were markedly elevated, and I wasn't really quite sure whether it was from the tumor, what's the reason behind that. His surface antigen was obviously positive, and his antibodies were also positive, and the rest of the hepatitis screen was negative. That time, the alpha-fetoprotein, when it came to me, it was not done. It was, unfortunately, we only have the one post intervention. He had a CT scan that Prof will probably, will share with us, So we're starting with the uncontrasted CT scan, cross-sectional imaging. Going down, we're seeing the liver coming into view there. You sort of get the impression on the right side, there's a hypodense mass over segment 6, 7, 8 there. And the left side is essentially normal. There were no features or there were no ascites or anything that we could see. And then on the next phase, this is the arterial phase. Because the HCC gets blood supply from the hepatic artery, you can see that lesion sort of enhancing there. It's a big lesion, almost about 10 centimeters to 12 centimeters there, mostly on the right side. I don't see any other lesions on the left side of the liver. So it's quite an extensive lesion that you could see there. And there was a cystic structure just near the segment 6. On the venous phase, should expect the lesion to display the phenomenon, what we call washout. You can see that it's less enhancing than previously seen on the arterial phase, and is less dense compared to the rest of the liver. So there is somehow a demonstration of a washout phenomenon. So based on this imaging, we're quite certain that this is probably an HCC until proven otherwise. And on the delayed phase, it just demonstrates that the lesion is more hypodense compared to the previous phases, which again just demonstrates the washout phenomenon. And the small lesion next to it, we thought it was a cyst. So in the imaging, we're quite, like I said, we're very confident that this is an HCC in a patient with hepatitis B infection, although it was treated.
Thanks very much, Rashid. Interesting case. So, this is a common problem that we faced with HCCs in non-cirrhotic livers. Does anyone have any questions or comments? Otherwise, I would maybe like to pose a question to one of the hepatologists, either Bilal or Masheko. How long, or what in a situation like this, when someone's diagnosed with an HCC, how would you get the viral load down? How long would you wait to do that? And what would be a acceptable viral load to have before you operate on the patient? Is one of the hepatologists there?
How's it, Mark? Sorry, man, I've just really joined. But to answer your question, you'd start the treatment immediately. Looking at the size of that lesion, I'm not sure if you'd want to consider maybe downstaging initially, which would still buy you some time. I'd probably go with 3TC, as it would have a more rapid onset of action compared to tenofovir, but obviously tenofovir being the more durable option. But I think as long as the patient is on some form of treatment, I wouldn't want to delay your surgery too much.
So just like 2 or 3 weeks, do you think that's reasonable?
Yeah. Make sure that he's tolerating it and try and get it done.
Are there any other questions or comments? With regards to downstaging, maybe a question for Professor Kricher. Is there a role for TACE or one of those options for downstaging in patients who do not have cirrhosis?
I don't know if Jake is still on, Mark.
Sorry?
I don't know if Jake is still on.
Okay. What is your thoughts on that, Ed? I mean, you know, TACE has usually been used as a, you know, either as a palliative treatment or sometimes as a sort of neoadjuvant treatment before transplant, but as a downstaging before a resection. Not that it would be necessary in this case, but
yeah, I mean, if we just look at the treatment options in this patient, I think it demonstrates quite nicely the limitations of the guidelines as they are. So this patient doesn't look as if he's got cirrhosis, and must realize that many of these guidelines, including the Barcelona criteria, are actually are assuming that there's cirrhosis in the liver. But if we assume that this patient had, say, cirrhosis, then this patient would actually have been beyond resection as well, and certainly is beyond ablation. So it's just an example how especially with a high prevalence of hepatitis B, and that being a major cause, that it's not, that we certainly have to look beyond the Barcelona criteria. I see Karan had his hand up. I don't know if he wants to comment. So sorry, let me just answer the question as well. Is that if the patient is resectable, and there's no reason to wait, I think the patient should undergo a resection. But certainly if the patient would be a candidate for transplantation, and there's issues with waiting lists for donors and so forth, it's not a bad option to buy yourself time and also test the biology of the tumor, if for instance there was a high alpha-fetoprotein.
There's a question about the alpha-fetoprotein level. So as you said, it wasn't done preoperatively. What was it postoperatively? Just was it normal?
Yeah, so interesting. I mean, that time when the patient was referred, yeah, the alpha protein was unfortunately not done, and that time the patient had also come with a result of biopsy, which also confirmed HCC. So I think it was probably a miss that we should have done the just for follow-up. But interestingly, post-op, the alpha-fetoprotein is actually not elevated. It's actually normal. It's actually 0. We didn't detect any protein post the intervention. Yeah.
So there's a few things to say about the alpha-fetoprotein. I mean, in the transplant literature now, we know that if you transplant with a very high alpha-fetoprotein, and what you define as high can vary, but probably over 500. Some people might say 1,000. You know, you have worse outcomes, and we'd often try and get it down with a TACE or something like that to see that the transplant will actually be beneficial. There's not as much evidence for doing that in a resection candidate like this. And I think even if the alpha-fetoprotein was very high and the lesion's resectable, you'd probably resect it. But you know, if it was like 50,000 before the resection, then you could argue, you know, that there's a high chance of recurrence post-operatively, and then sometimes in those situations you could maybe give TACE or something and see what happens before you subject the patient to a morbid resection. Just those are just my thoughts on it. And also, it's quite nice to know if it was high and it's gone down to normal. You know, then you can use it as a marker for recurrence down the line. But like I say, it's not essential. So it sounds like this patient's had a really good result. I don't know if there's any other comments or questions.
I think Karan has got his hand up, and Rashid, you should maybe just tell us what you did and whether there was cirrhosis in the liver.
Yeah. So we actually walked him up for a right hemihepatectomy because, I mean, it was also in segment 8, so we felt a right hepatectomy will actually give us clear margins. And that's what we did more than a month ago. The margins were clear. He did well post-op, other than he had a minor bile leak that we sorted with ERCP, and so far he's doing okay. Yeah, and there was no cirrhosis clinically when we are operating. Even the histology did not really show cirrhosis. It was only mild fibrosis, but not really extensive fibrosis in the normal liver tissue surrounding the tumor.
Karan.
Yeah, so my question was just going to be about the cirrhosis as well. So in a patient like this who's got hepatitis B, we know it's a risk factor for de novo HCC. We know it's a risk factor for cirrhosis as well. The aim is to treat the hepatitis B pre-operatively and bring down the viral load to an acceptable level. Would you do a fibroscan or a liver biopsy of the normal liver for every one of these cases, given the fact that they have a risk factor for cirrhosis, to rule it out? Or would it be someone who's got preserved liver function, you know that you're leaving adequate liver volume behind with a right hepatectomy? Would it be okay to just proceed with surgery and then go ahead with the right hepatectomy?
Yeah, so that's a really good question. I mean, Rashid, if you'd got in there, and there was a cirrhotic liver, would you have felt comfortable proceeding, do you think?
Mark, to be honest, I don't think I would have proceeded if it was a really cirrhotic liver, because of the risk of post hepatectomy liver failure. And the thing is, we don't really have support we don't have a pathologist, and we don't have transplant facilities. So I would have probably would have backed off and then maybe resort to a transarterial chemoembolization, which we have available here in Windhoek.
So, Karan, also another problem that we've faced, I mean, not that everywhere has a fibroscan available, but it's problematic if the tumor's on the right side of the liver. To do a fibroscan, it can sometimes give you, it's not really like representative result. So I suppose it would not have been unreasonable to stick in a lap scope and maybe have done a biopsy of the so-called normal liver. Yeah.
Mark, we can ask Bilal. I think has got quite a bit of experience with fibroscan. I don't know, Bilal, what is your opinion on the role of fibroscan in such a patient?
Yeah, I'd agree with Mark there, but you get other forms of elastography. Shear wave, for instance, can assess and that's using certain ultrasound probes where they have the software in it, and it can give you a better idea of specific focal points in terms of fibrosis, where you can select areas of interest, but not our current transient elastography using the FibroScan device. I'd agree with Mark's opinion there. I think the other fact, I did come late to this case, so I missed quite a bit of it, or I'm not sure how much I missed. But I see that he's not cirrhotic. Your portal hypertension and your hepatic venous wedge pressure is also an important point in deciding who you're going to be able to successfully resect versus transplant.
Okay, I think I think that was a nice case, and I think we should probably move on to the next case, which, as I mentioned, as Yalda Ziai, who's our fellow at Twitter, is going to present a case. So let's move on to that.
Hi, thanks, Mark. Hi, everyone. I'm going to be presenting a case. Is Mr. JC. He's a 72 years old male, retired teacher, non-smoker, and does not drink any alcohol. He has a family history of 2 of his brothers died from HCC, and they were both a case of undiagnosed hepatitis B virus. And the patient himself is a known case of hemochromatosis and the chronic hepatitis B virus, which was following up with the liver physicians. So he was found to have hepatitis B virus as a routine checkup in the health check. And then when he was followed in the liver clinic on routine ultrasound abdomen, he was found to have a liver lesion. For his HPV, he was on tenofovir. Examination, general and abdominal examination was completely unremarkable for him. A good performance status of 0, except the hemoglobin, which was a slightly high of 16 because of hemochromatosis. The rest of his blood works were unremarkable. And alpha fetoprotein as well was completely normal for him. As I mentioned, he had an ultrasound, which was followed by MRI. We used Primovis MRI, which was a liver-specific contrast, and we can see yes. So we can see that this is a T1 image. We can see that there is a lesion. There is a lesion in the segment 8 of the liver. It's a hypotense in the T1 cuts, and there's nothing else in the liver. On the T2 imaging, the lesion was not very clearly visible. It was very difficult to see. As you can see here, if you roll down, it's very difficult to see the image, the lesion on the T2 images. Going to the arterial phase, it showed a clear arterial enhancement. As you can see here, it's just taking up the contrast and clear enhancement. And venous phase, yeah, that was arterial phase. And in the venous phase, the lesion is becoming iso-intense. Again, it's very difficult to spot. It's kind of difficult to spot the lesion. But when we are going for the delayed imaging after 20 minutes, we can see that the lesion is very clear. In segment 8, it's completely hypointense with complete washout of the contrast, which is corresponding to LIRAD 5 imaging.
Okay.
So, thanks, Yalda. Any comments on what people would consider doing now, or any more information that anyone would like to request? Yalda, just sorry, the patient has just a point to make. A patient has cirrhosis. So the LIRAD criteria, strictly speaking, should only apply to patients with cirrhosis. The last patient very likely had an HCC, but it's not strictly speaking correct to use the LIRAD criteria when a patient's non-cirrhotic. Eda, you have any comments?
No, not really, Mark. But I mean, we can just, if we summarize this patient, so a healthy 70-year-old male with two risk factors. So hepatitis B that he probably got at birth because two of his brothers passed away because of HCC, and only after that, the connection was only made after his hepatitis B was discovered. And then hemochromatosis as well. Very good performance status, well preserved liver function, and that would again leave one with clearly a patient that will be treated with curative intent, but with all three of the options available. So transplantation, if you're in a country where there's a lot of livers available, but I mean this could be resected and or ablated, and I think just going back to the evidence that is out there, I think in this case, clearly resection would be the treatment of choice. So if I can just take it a little bit further, so this patient was actually ablated percutaneously for this lesion because that's what he wanted, and then was followed up, and we'll go to the follow-up imaging just now. But just one comment is that when it comes to percutaneous ablation, that's the point that I wanted to make, is that one should not consider ablation as a percutaneous method. I think one of the reasons why ablation is coming off second best compared to many of the other methods is it's assumed that it has to be percutaneous, otherwise you don't use it. That is really not true. If you go look at the evidence out there, that your best ablation outcomes are with open ablations, where you can really, from any angle, get onto that tumor. And if we're going to use this as a curative intended treatment, we should not. This is not a method that's limited to percutaneous intervention. I mean, the equivalent could be, if you can do a liver resection laparoscopically, you should do all liver resections laparoscopically. It doesn't carry. Some should be done open. Some certainly could be done laparoscopic, but your access to the tumor is really one of the key factors, and it should be optimal. And especially in this patient, I'm just going to take you through the imaging here again. You look where this tumor is sitting. It's really quite high up on the liver, very difficult to get there percutaneously. You probably have to go through through pleural space, and you're a little bit worried about burning on the diaphragm as well. So certainly percutaneous ablation in this case, I think one should be very careful with. But I mean, if you had this liver slightly mobilized, distance it from the diaphragm, and you had with ultrasound on the liver, needle properly placed, and you burnt a 5-centimeter hole there, I've got difficulty to see other than that the outcome must have been as good as resection. I think Sandy had a hand raised here.
So Sandy is a HPB surgeon in Cape Town, and he's just raised his hand. Prof, do you have something to add?
I'm a retiree, as you know, Mark. And I'm just starting a question. Obviously, the focus on ablation versus resection is largely related to the oncological outcome. But surely in a 72-year-old, is there anything on the complications of these two methods in equivalent groups? Because it seems to me that, and personally, you know, if you did a laparoscopic thing, got it away from the diaphragm, and you could see it nicely, that seems like a minimally invasive solution for a 72-year-old. But is there any data on complications in the elderly with comparing these two options for curative intent?
My understanding is that there is some data on patients who have pre-ablation to resection, that there's shorter hospital stays and lower complication rates, but you know, at the cost of potentially higher local recurrence rates. I don't know. Would you agree with that, Ed?
Yeah, so as I said, I'm very wary of comparative studies if they're not randomized, and the inclusion criteria should be that the lesions are optimal for both treatment options, and so often they are not. So in your inclusion criteria, the lesion should be absolutely optimal for both treatment methods. And if you see here, for instance, this lesion, and I take your point, and a very valid, Sandy, is an ablation here, I think, is definitely less invasive than a resection. Your bi-leak rates are basically zero, it's a very quick procedure. As long as you distance it properly from the diaphragm, you're not going to create any collateral damage. The point I wanted to make is, especially if, and I know there are centers in Africa, and I think at Wendy's hepatitis, viral hepatitis meeting, they presented such a case in a facility where the only thing they could do was to inject alcohol. And I think in that case, if the alcohol injection is going to be better when you open the patient or do a laparoscopy, if that is possible, I think one should actually go for that. I think there was another hand up.
I didn't see that. So let me just see. Let's see who it was. Okay, whoever has a comment, just if you can just introduce yourself, just say where you're from.
I think Karan's got a hand up. Mark.
Karan.
Yeah, I've got a hand up again. Just a quick question about the choice of contrast material that we used for this MRI. We clearly know that when it comes to colorectal liver metastases or anything non-hepatic or non-hepatocellular, Primavist is clearly a superior contrast agent. But for HCCs, is there any difference between Primavist and normal gadolinium as contrast? The reason I'm asking is because we don't actually have Primavist available to us in Kenya at the moment. So I'm just wondering if there was a reason Primavist was chosen as a contrast medium here, and what implications it would have if it's not available.
I'm just going through the names here. I don't know if we've got a radiologist on. If we have, they're really welcome to comment.
My view on it and my understanding is that gadolinium is better for if you want to if you're not sure what the lesion is, and it's better for distinguishing different types of lesions such as an HCC from a colorectal liver metastases. But Primavist, because you get the parenchymal phase or the hepatic phase, is really good for detecting, you're less likely to miss a lesion if you use Primavist. And I think, well, we certainly usually use Primavist, but it is more expensive. I don't think it's, I think gadolinium is a good alternative if you don't have Primavist available.
Yeah, Mark. So I think just quickly, the difference between the two is that with a purely intravascular contrast, as for CT, that it will just keep on circulating through the vascularity and it's excreted through the kidneys. Primavist is a dual excretion, so 50% through the kidneys, 50% through the hepatocytes, and it does give you the additional advantage of that anything that doesn't contain functioning hepatocytes will be a dark spot on the late. So I'm sharing my screen again. You can see that.
Professor Thompson has raised his hands again.
Sorry, Mark, just quickly. The other thing that one has to also be aware of is that there are about 5 or 10% of HCCs are going to be hypovascular. They're not going to show the typical pattern. And then especially in well-differentiated HCCs, where the hepatocytes are still functioning, but there are no bile ducts, obviously, draining it, that you get in the late phase, delayed phase, after 20 minutes, you will get a high signal intensity lesion because it takes up the Primavist, but can't excrete it.
Sandy, did you have something to say?
No, just the one question. No. Maybe I should take my hand down.
Okay. Just one. We're getting towards the end, but Bilal mentioned measuring the wedge pressure and portal hypertension as being a contraindication to resection. I think one of the problems is that investigation is really not very widely available, probably outside of transplant units. So, I mean, I was just thinking, you know, there are other surrogates for portal hypertension, such as thrombocytopenia, big spleen, and the presence of venous collaterals. But having said that, do you think portal hypertension is as an absolute contraindication to liver resection, or do you think there are occasions where where you can sort of still resect a patient who has portal hypertension?
I think you have to weigh it up. If there's still good liver function, and portal hypertension is the only challenge, there could be a place. I mean, there's good data on resections performed outside of all the criteria in the Barcelona algorithm. The one we know that one should not sort of step over is if there are any signs of vascular infiltration. The outcomes are terribly bad. But I think in patients with portal hypertension, where the liver function is reasonably well preserved, there is a place. But I think the calls there, to make the calls there, get more complicated. And that is probably best done in centers with a bit of experience in this. Mark, just in the interest of time, I think we should just quickly finish off this case. I'm just going to, Yalda, I'm just going to stick onto the arterial phase, if you quickly take us through that. And then we actually have to conclude because we're approaching 1 hour. So this patient,
as you mentioned, this patient had a local ablation, and then after a few months and repeated MRI, this is in the arterial phase. We can see that there is this cavitary lesion in the area of the previous lesion with some hyper intense tissue surrounding it. Maybe there are some nodularities as well. So this just confirms that the previous ablation did not work and the disease is still present. And
yeah, so I think that's the message in the whole story was that the ablation wasn't optimal for the reasons that we've mentioned, and the patient was subsequently resected laparoscopically for the recurrence.
Thanks, Ed. So I just have one last comment before I end. It just does make the point, it's very useful if you do an ablation to get imaging within about a week or two after the ablation, because otherwise you have nothing to compare it to later on. And you would expect over time for the ablation zone to become smaller. And if it's getting bigger, then you're concerned that obviously there's a recurrence. So I think we've sort of come to the end of the time. I hope that was everyone felt that was useful. Just to thank ECHO and the University of New Mexico, the ECHO India team. There is a feedback form available, and recordings are available on the Gastro Foundation website. And just thanks to the Gastro Foundation and to Cheryl and Karen for organizing the meeting. These meetings, the GECCO meetings are held every Wednesday, but we'll be having another one of these in about 4 or 5 weeks. And we'd really appreciate people sending through cases that we could discuss. And those can be sent either to myself or to Professor Jonas. Thanks very much, everyone.
Okay, thanks a lot.
Thank you very much.